Hello everybody and welcome to our module on the nephrotic syndrome. The nephrotic syndrome is a glomerular disorder where protein is lost in the urine and therefore protein levels in the body generally fall. And because protein is lost in the urine and protein levels are low in the body, that leads to all the clinical features that define the nephrotic syndrome. First of all, patients with the nephrotic syndrome have proteinuria. We'll talk about this in detail in a minute. And this makes their urine frothy, which they often notice and complain of to their physician. Immunoglobulins are proteins, so those are lost in the urine, and this makes patients with nephrotic syndrome vulnerable to infection. Antithrombin 3 is a protein that prevents thrombosis, and it's lost in the urine, and this makes patients hypercoagulable, and so therefore patients with nephrotic syndrome are at higher risk of developing thrombosis, like DVT or PE. And lastly, albumin gets lost in the urine, and this leads to a couple of clinical effects. First of all, it lowers the plasma oncotic pressure. The plasma oncotic pressure holds fluid in capillaries, so when it gets low, fluid leaks out of capillaries into tissue beds, and this causes edema, which patients always have with nephrotic syndrome. In addition, because that fluid is leaking out into tissue beds, there's a lower effective circulating volume. This activates the renin-angiotensin-aldosterone system, and this can lead to hypertension. Activation of the RAS also causes sodium and water retention, and that makes the edema worse. And then when albumin is lost in the plasma, the liver ramps up its metabolic activity to try and replace the lost albumin, and this leads to the liver producing more lipids, and therefore hyperlipidemia is a classic finding in nephrotic syndrome. And if the hyperlipidemia is severe, it can lead to findings in the urine that you can see on urinalysis, and the two classic findings in nephrotic syndrome are the presence of fatty casts and oval fat bodies. So on this slide I've summarized the clinical presentation of a patient with the nephrotic syndrome. The patient will report frothy urine, and the patient will have swelling of the ankles, and they will have pitting edema, like what's shown in this picture. If you press your finger down, it will leave a pit behind. That's pitting edema. In addition, patients with nephrotic syndrome classically have swelling around the eyes. This is called periorbital edema. Periorbital edema can occur in any edematous state, but it's a classic finding in nephrotic syndrome. The serum total cholesterol will be high, usually greater than 300, and there will be protein in the urine. And if you ask the patient to collect their urine for 24 hours, the classic number for the amount of protein in nephrotic syndrome is more than 3.5 grams per day. This is a very, very large amount of protein in the urine, and when the protein levels in the urine are this high, it's called nephrotic range proteinuria, because only the nephrotic syndrome usually causes protein levels this high in the urine. And then, as we mentioned on the last slide, these patients are at a higher risk of infection, and they have an increased risk of thrombosis. If you suspect a patient has the nephrotic syndrome, the best initial test is a urinalysis. This can tell you that there's protein in the urine and also help to define whether or not the protein losses are in the nephrotic range. If you look at this table on the screen here, the left column shows urinalysis findings in terms of protein. They range from negative to 4+. In the right column, I've shown the grams per 24 hour of protein excretion that goes with the urinalysis findings. So patients with nephrotic syndrome are losing more than 3.5 grams per 24 hours, so they're going to be in this range here, and their urinalysis should show either 3+ or 4+ protein. Now, one caveat to this, the urinalysis preferentially detects albumin, and urinalysis is notorious for being insensitive to immunoglobulins. Normally this doesn't matter because most patients with nephrotic syndrome are losing albumin, but one exception is multiple myeloma. Patients with this condition produce lots of immunoglobulins, and the way they lose protein in the urine is by having immunoglobulins pour into the urine. So it's rare, but multiple myeloma can present with the nephrotic syndrome, and when it does, the urinalysis will be negative, and that's because there's no albumin there, it's all immunoglobulins. After a urinalysis, the definitive test for nephrotic syndrome is a renal biopsy, and we'll talk later about various renal biopsy findings that you can see in patients who have the nephrotic syndrome due to different causes. So a urinalysis can tell you that a patient has lots of protein in their urine consistent with the nephrotic syndrome. But if you want to know exactly how much protein, you need to do what's called a 24-hour urine collection. This is where you basically ask the patient to carry around a bucket and urinate in the bucket over the course of 24 hours. Normally, only a small amount of protein is lost in the urine, less than 150 milligrams per day. And as we said before, the nephrotic range for proteinuria is greater than 3,500 milligrams a day, or 3.5 grams per day. Because a 24-hour urine collection is inconvenient for patients, there is an alternative, which is the urine protein to creatinine ratio. This is a number that you can get from a urine sample, and it estimates the 24-hour protein excretion, and it's much easier to obtain than a 24-hour collection. And so what you will get back from the lab is a ratio of protein to creatinine, And if the ratio is 3.5 to 1, that implies 3.5 grams of protein are being lost in 24 hours, and that's nephrotic range proteinuria. And once again, the reason we call losses of protein more than 3.5 grams in 24 hours the nephrotic range is because that only happens if you have a glomerular problem. There are many other causes of proteinuria, but they cause milder degrees of proteinuria. When you see it in this range of more than 3.5 grams per day, that's a glomerular problem. In a minute, I'll talk about the specific causes of the nephrotic syndrome and how to treat them, but first I want to make a couple general treatment points. For any patient with the nephrotic syndrome, ACE inhibitors and ARBs are usually prescribed. The reason is these treat the hypertension that's present in nephrotic syndrome, and they also can improve the proteinuria. The hyperlipidemia of nephrotic syndrome can be treated with statins, and the edema will improve if patients restrict their sodium intake. The less sodium they take in, the less edema they will have. Shown on this slide are the major causes of the nephrotic syndrome, and we'll go through all of these in the next few slides. This last one, membranoproliferative glomerulonephritis, we'll talk about at the end of this video. It's really in a class of its own. It can cause similar features to the nephritic or the nephrotic syndrome, and we'll talk about this at the end of this video. The first cause of nephrotic syndrome is minimal change disease, and in order to understand minimal change disease, we have to review the components of the glomerular filtration barrier. Shown on this slide is a cartoon of a glomerular capillary and Bowman space, which is in the nephron. So blood comes in this way and goes out this way, and certain elements of the blood can pass through the glomerular filtration barrier and enter the urine. Proteins should mostly stay behind. Only a tiny bit of protein is allowed through under normal circumstances. But what goes wrong in the nephrotic syndrome is that lots of protein gets through and enters the urine in Bowman space. There are three components to the glomerular filtration barrier. The first one is the capillary endothelium. That's shown in red here. These are cells that line the capillary. Next element is the basement membrane, and then on Bowman space there is a second epithelial layer made up of cells called podocytes. And these podocytes have little foot processes which are extensions of the cell that wrap around the capillary. And so in order to maintain the glomerular filtration barrier and keep protein in the capillary, all three of these elements, the capillary endothelium, the basement membrane, and the podocytes, need to be functioning normally. What happens in minimal change disease is the foot processes of the podocytes become flattened. This is referred to as effacement of the foot processes, and as a result this podocyte part of the layer doesn't work normally, and that allows protein to leak through and enter the urine. In minimal change disease, because of the effacement of the foot processes, there's loss of the anion or negative charge barrier in the glomerular basement membrane. So normally the filtration barrier repels negatively charged substances, and albumin has a negative charge. In minimal change disease, because of the effacement of the foot processes, negatively charged substances are not repelled and they pass through and enter into Bowman space. The trigger for minimal change disease is cytokines. Cytokines lead to damage to the podocytes. Often this is idiopathic, but there is a strong association between minimal change disease and Hodgkin lymphoma. And that should make sense to you if you remember that in Hodgkin lymphoma there are Reed-Steinberg cells that produce lots of cytokines. So it makes sense that those cytokines could travel to the kidneys and cause minimal change disease. After a renal biopsy is done, there's three ways we examine the renal tissue under the microscope. The first way is through standard light microscopy, and that will be entirely normal in minimal change disease. The second way is by using immunofluorescent staining, and there are no important immunofluorescent staining findings either in minimal change disease. The only finding under the microscope in minimal change disease is effacement of the foot processes, which can only be seen with very powerful electron microscopy. If you look at the bottom left side of the screen, this is a glomerular capillary, this is the basement membrane, and over here we have the urinary space. This is Bowman space, this is within the nephron where urine is forming. These are the podocytes, and these are normal appearing podocytes, and this is an example of a normal glomerular capillary setup on the left. On the right is a patient with minimal change disease. This is the capillary, this is the basement membrane, and these are the foot processes. Notice that they're flat, they don't stand up straight like the image on the left. That is effacement of the foot processes. It can be visualized under electron microscopy, and that's the only important finding on renal biopsy in cases of minimal change disease. Minimal change disease sometimes has an immunological trigger that occurs days before the onset of the nephrotic syndrome. One of the classic ones is a viral infection like an upper respiratory infection. Others are an allergic reaction like a bee sting or an immunization. And the idea here is that all of these things can trigger the production of cytokines, and those cytokines can go to the kidneys and trigger minimal change disease. The proteinuria in minimal change disease is selective, and by this I mean that only albumin ends up in the urine, not other proteins like immunoglobulins. Only negatively charged proteins like albumin get through in minimal change disease, not other proteins, and for this reason, patients with minimal change disease are not at risk for infection the way other patients are, because immunoglobulins remain behind in the capillary. And this selective proteinuria is relatively unique to minimal change disease. It's different from other glomerular diseases that we'll talk about later where the proteinuria is non-selective. And you should know that minimal change is the most common cause of nephrotic syndrome in children. The classic presentation in a board question is a child with a recent upper respiratory infection who develops nephrotic syndrome. Minimal change has a favorable prognosis. Most patients recover, and it is famous for responding very well to steroids like prednisone. Remember that the problem is cytokines, and so if you can get rid of those cytokines by administering steroids and suppressing the immune system, then the nephrotic syndrome will get better. And this is unique among the causes of nephrotic syndrome. None of the other ones respond so well to steroids. Minimal change disease is in a special category of responding well to steroids. Our next cause of the nephrotic syndrome is FSGS. FSGS stands for focal segmental glomerulosclerosis. This is a renal biopsy from a patient with FSGS on the screen here. This is what it looks like under standard light microscopy. It's called focal because only some glomeruli are involved. This is a healthy glomerulus up here, and this is one with pathologic changes due to FSGS. Glomerulosclerosis is this pink material here that's deposited in parts of the glomerulus. This is an accumulation of proteins, and just like the proteins leak into the urine, they also can accumulate in the glomerulus as shown here. And finally, it's called segmental because in the affected glomeruli like this one, some of the glomerulus is normal. It's only segments of the glomerulus that are affected. The cause of FSGS is podocyte damage from an unknown agent. FSGS is sort of famous because after a kidney transplant, it will recur, sometimes as quickly as within 24 hours. So it's always been believed that there is a circulating agent that damages the podocytes, but no one's ever been able to figure out what that agent is. And so patients with FSGS will present with nephrotic syndrome, and if you do a renal biopsy, it will look like this under light microscopy. If you look at the glomeruli under electron microscopy, you can see effacement of foot processes in FSGS the same way you see that finding in minimal change. In fact, some people believe minimal change and FSGS are part of a spectrum, with minimal change being the milder disease and FSGS being more serious, because as we'll see in a few slides, FSGS often leads to chronic kidney disease. FSGS is divided into primary and secondary FSGS. Primary FSGS occurs in patients with no other disorder that might have triggered the glomerular disease. Secondary FSGS occurs among patients who have certain conditions that are known to be triggers for this form of glomerular disease. There are many secondary causes of FSGS, but I've written some of the important ones on this slide. So FSGS can be secondary to HIV, sickle cell anemia. It occurs among heroin users, presumably because when they inject heroin, they also inject other substances into the blood, which accumulate in the kidneys. And then it's also associated with massive obesity, like this man right here. Patients who receive interferon treatment for hepatitis C or hepatitis B, or sometimes for malignancy, some of these patients go on to develop FSGS. And then finally, FSGS is well described to occur in people who have lost nephrons for any reason. So this could be someone who was born with a single kidney. This could be someone who donated a kidney, or someone who had a surgically removed kidney for cancer. Any patient who's lost nephrons is at increased risk later in life for developing FSGS in whatever kidney tissue they have that is still functioning. The diagnosis is made by renal biopsy. On light microscopy, you will see those findings of FSGS that we looked at a few slides ago. Electron microscopy isn't routinely done, but if it is done, you can see effacement of the foot processes. There really aren't great treatments for FSGS. If patients have an associated cause like HIV or Hep C, if you treat these things, sometimes the FSGS gets better. There's some evidence for immunosuppression with steroids and other drugs, but this is controversial. This is usually only done in primary FSGS. And then the thing you want to always remember about FSGS for your board exams is that it often progresses to chronic renal failure. 40 to 60% of patients within 10 to 20 years will end up on dialysis like this man here. So as I said before, a lot of people think of minimal change disease and FSGS as occurring along a spectrum of podocyte injury. Minimal change disease is more at the benign end. It usually gets better. It responds well to steroids. FSGS is at the more severe end. It doesn't respond as well to treatment, and it often leads to chronic kidney disease. Our next cause of the nephrotic syndrome is membranous nephropathy, and it's called membranous because patients with this disorder develop thickening of the glomerular basement membrane. If you look at these images on the slide, a normal glomerulus is shown on the left, and notice how thin the basement membrane is of the capillary here. The image on the right is from a patient with membranous nephropathy, and you can see that the basement membrane is much thicker here. Membranous nephropathy is a disorder of immune complexes. Immune complexes are antibodies that bind to antigen and they deposit and build up in the glomerulus, and that's what makes the membrane thick. And because membranous nephropathy is a disorder of immune complexes, immunofluorescence microscopy is very useful. In immunofluorescence microscopy, you take a renal biopsy sample like the one shown on the screen here, and you add an antibody that will light up if it binds to its target. And the antibodies that you use in membranous nephropathy are against IgG and C3. There's lots of IgG and C3 in the glomerular basement membrane, and therefore it will light up in immunofluorescent staining. And because these immunocomplexes are sort of deposited randomly here and there within the basement membrane, you get a so-called granular appearance on immunofluorescence microscopy. That's what's shown on the slide here. You can see that the pattern by which it lights up is sort of this lumpy, bumpy pattern, and that's from the random distribution of those immune complexes. And so you should note that immunofluorescence microscopy is not very useful in minimal change disease or FSGS, and that's because those are not immune complex disorders. It is useful in membranous nephropathy, and that's because antibodies and complement proteins can be tagged by fluorescent antibodies and will light up on immunofluorescent staining. The classic finding on electron microscopy in membranous nephropathy is the presence of subepithelial deposits. If you look at this electron micrograph on the screen, this is the center of the capillary here. Bowman's space is over here where the urine is forming, and you can see that there are these dark lumps present. These are subepithelial deposits. They're called subepithelial because they form beneath the podocytes, beneath the epithelial layer. And these deposits make the basement membrane appear thick, as we've already discussed. And then the basement membrane is sometimes said to take on a spike and dome appearance in membranous nephropathy. The idea here is that there are these subepithelial deposits, and then the podocytes lay down basement membrane on top of those deposits, and that tends to result in a basement membrane that looks like a spike and dome. So to summarize, membranous nephropathy has important findings on light microscopy, immunofluorescence, and electron microscopy. What you see under light microscopy is the basement membrane thickening, like we talked about earlier. You see granular staining for IgG and C3 on immunofluorescence, and you see the subepithelial deposits on electron microscopy. So membranous nephropathy is associated with a number of other conditions, and we'll talk about that in a minute, but you should know that the most common form is idiopathic, with no obvious association with some other disorder. And among patients with the idiopathic form, almost 80% have autoantibodies directed against an antigen called PLA2R, which stands for phospholipase A2 receptor. It's a protein antigen that is expressed on podocytes. And so one test that can be done in patients with membranous nephropathy is to screen the serum for anti-PLA2R antibodies. And if that test is positive, it suggests that the patient has membranous nephropathy. And this can sometimes avoid the need for biopsy. If a patient has the nephrotic syndrome and they have positive antibodies, some patients will simply be treated going forward as if they have membranous nephropathy without doing a biopsy to make the definitive diagnosis. I told you that membranous nephropathy is caused by immune complexes, which are antibodies bound to antigen. And if you know that, it's an easy way to remember that patients with lupus can develop membranous nephropathy because lupus is a systemic immune complex disorder. Now, most patients with lupus who develop renal disease develop the nephritic syndrome, which I talk about in another video. Most patients develop what's known as diffuse proliferative glomerulonephritis, but sometimes patients with lupus develop heavy proteinuria that can lead to the nephrotic syndrome, and if that happens, membranous nephropathy is the cause. And this occurs in about 10 to 15% of patients with lupus who develop renal disease. And this is a picture of a woman with lupus here with the classic malar rash on the cheeks. So I told you earlier that membranous nephropathy is associated with a number of disorders, so let's talk about those now. First of all, many patients with solid tumors like colon cancer, lung cancer, or melanoma will develop membranous nephropathy. It's thought that the tumor triggers the synthesis of antibodies, and that forms immune complexes which deposit in the kidneys. Infections with hepatitis B and hepatitis C are associated with membranous nephropathy. And a number of drugs, all of which can be used to treat rheumatoid arthritis, are associated with membranous nephropathy. These include penicillamine, gold, and NSAIDs. And so if you see a board question describing a patient with the nephrotic syndrome and they have some type of solid tumor or hepatitis or rheumatoid arthritis, this is one of the things you should think about, is that they may have membranous nephropathy. Some other things to know about membranous nephropathy. This is the most common cause of nephrotic syndrome in adults. When children get this disorder, they have an excellent prognosis and usually recover their kidney function. Some adults with membranous nephropathy progress to go on to develop end-stage renal disease and require dialysis. In a lot of patients, spontaneous remissions occur, but some patients go on to developing rising creatinine and eventually go on to need dialysis. And there are well-described risk factors that identify high-risk patients who are likely to progress to end-stage renal disease. Generally, these are patients who are older and who have elevations of BUN and creatinine. And in those patients who are considered high risk, they are sometimes treated with rituximab, which is an antibody drug, steroids, or cyclophosphamide. Okay, our next cause of nephrotic syndrome is diabetic nephropathy. So patients who have diabetes have a process occur in their kidneys called non-enzymatic glycosylation. This is where glucose molecules get added to structures in the kidneys. And when this happens in the basement membrane, it can lead to leakage of protein. And you may know that diabetics are routinely screened for the presence of protein in their urine because that's an early sign of diabetic kidney disease. Over the long term, if kidney disease progresses in diabetes, this can lead to sclerosis of the glomerulus, and therefore many diabetics go on to require dialysis. But the bottom line here is that proteinuria is an element of diabetic nephropathy, and in a minority of cases, the proteinuria can be so severe that patients develop the nephrotic syndrome. This isn't what usually happens, but it can happen, and therefore that's why diabetes is considered one of the potential causes of nephrotic syndrome. Another cause of nephrotic syndrome is amyloidosis. So amyloidosis is a disease where amyloid proteins deposit in tissues throughout the body. And these amyloid proteins have a classic appearance under the microscope. They always display apple green birefringence when you stain them with the Congo red stain. And this is an image of amyloid proteins under polarized light with apple green birefringence. And the thing to know about amyloidosis is that the most commonly involved organ is the kidneys. And just like with diabetes, most patients who have amyloid kidney disease do not develop nephrotic syndrome, but a minority of them do, and therefore in any patient with new onset nephrotic syndrome, amyloidosis is a consideration, and that's something you could find when you do a renal biopsy. Our last disorder we'll talk about in this video is MPGN, which stands for membranoproliferative glomerulonephritis. MPGN is a group of rare glomerular disorders, and in reality, they present with a mixture of features, some of which resemble the nephritic syndrome and some of which resemble the nephrotic syndrome. And for this reason, you will sometimes see them in lists of causes of both nephritic and nephrotic syndrome. In reality, the way these patients present is with some degree of renal dysfunction, so the BUN and creatinine will be up, and there's usually hematuria, and these features are reminiscent of the nephritic syndrome. In addition, these patients have proteinuria and sometimes is in the nephrotic range, and that's why you'll see MPGN as a cause of nephrotic syndrome. And all the subtypes of MPGN are immunologic disorders, so in general, they're treated with steroids and immunosuppressants. There are two major types of MPGN. The type 1 form is more common. The type 2 form, which is also called dense deposit disease, is more rare. MPGN is called membranoproliferative because the membrano refers to the fact that patients with this condition have thick basement membranes. The word proliferative is in the name because these patients have a proliferation of mesangial cells and mesangial matrix. The mesangium is the tissue that surrounds the glomerulus. So if you look at the bottom left side of the screen, this is a normal glomerulus, and note that there are lots of white spaces. Those are capillary loops. If you look at the right side of the screen, this is a patient with MPGN, and in general, it just is much more thicker and denser. That's because there's hypercellularity, and that's because the walls of the basement membrane are thick. MPGN type 1 is an immune complex deposition problem, just like what we talked about before in terms of membranous nephropathy. These patients have IgG antibodies that activate complement, and that's what leads to the pathology in the glomerulus. The immune complexes split the basement membranes, and therefore you get this appearance on microscopy that's referred to as a tram track appearance, and that's because of the split basement membranes. If you look at this image on the screen, at the tip of the arrow, you can see this split basement membrane here. It looks like a railroad track. It's called a tram track, and that's a classic finding in MPGN type 1. It occurs in about 80% of cases. Because MPGN type 1 is an immune complex disorder, just like membranous nephropathy, you can use immunofluorescent staining in cases of MPGN type 1, just like with membranous nephropathy. Remember, immune complexes are those little antibody-antigen complexes, and they find their way into the basement membranes of the glomeruli in MPGN type 1. So if you add fluorescent antibodies that target IgG and C3, you will get a granular appearance just like you get in membranous nephropathy. MPGN type 1 can be idiopathic or primary. However, you should be aware that it's often secondary to hepatitis B or hepatitis C. MPGN type 2 is called dense deposit disease, and in contrast to type 1, this is not mediated by immune complexes. It's mediated by complement activation through a mechanism that is not clear. IgG is usually absent in this disorder, and that distinguishes it from type 1. The classic finding in MPGN type 2 on electron microscopy are these electron-dense deposits in the basement membranes. You can see these dark, thick basement membranes. It looks like a ribbon of black along the basement membranes. That's the classic finding in MPGN type 2. So under microscopy, you can see these dense deposits, and if you do immunofluorescence, it will show evidence of C3 because this is complement mediated, but not IgG because this is not immune complex mediated. There's an antibody that can be found in the serum of patients with MPGN type 2. It's called C3 nephritic factor. It's an antibody that stabilizes the complement pathway convertase, C3 convertase, and this is believed to play a role in overactivation of the complement system. This antibody is found in more than 80% of patients who have MPGN type 2. C3 convertase normally activates the alternative pathway of the complement system, and C3 nephritic factor stabilizes this convertase, leading to overactivity of the alternative pathway. And because complement is overactive in this disorder, you can see hypocomplementemia on serum testing, classic finding in MPGN type 2. That's due to the low levels of C3, which are being consumed by overactivity of the alternative pathway of the complement system. MPGN type 2 is mostly a disease of children. It usually occurs in children 5 to 15 years old, and half of those children go on to develop end-stage renal disease within 10 years. So putting it all together, MPGN is a really rare disorder, but in terms of your board exams, it's going to be a patient who presents with renal failure, hematuria, and lots of protein in the urine. On light microscopy, the glomeruli will look hypercellular like this. And then if it's a patient with the type 1 form, remember that's an immune complex disorder, and on light microscopy you see those tram tracks, and this is associated with hepatitis B and C. If it's a patient with the type 2 form, remember that's complement mediated. On electron microscopy, you see those dense deposits in the basement membranes, and this is the type that tends to occur more often in children. And that concludes our module on nephrotic syndrome.